so much for inviting me to come talk. I'm really excited to have a conversation about this paper. It was a learning experience for me as well, as someone who's new and limited in my understanding of HIV cure research. Our co-author, Corinne Dubé, is like, just a rock star in that arena. And so it was great to work with her on this project, as well as the other folks. So I'm just going to dive in. My goal is to just sort of do a brief background of what we know about HIV among trans people, and then into the paper. So this is a slide that basically shows the US HIV prevalence, and the top bar is the HIV prevalence among the US population in general. That's an estimate from the Centers for Disease Control and Prevention. And it's about 3 in every 1,000 people in the United States is living with HIV. The second bar is for gender non-binary people. And unfortunately, we don't have any systematic data collection on HIV status among gender non-binary people. So this is drawn from the US Transgender survey that was conducted in 2015, and where people were asked to self-report their HIV status. And about 4% or 4 in every 1,000 gender non-binary folks reported living with HIV. And the bottom 2 bars for transgender men and transgender women are drawn from a meta-analysis that was done by the CDC. So basically they pulled together all the studies they could find that had laboratory confirmed HIV status for transgender people, and they estimated an HIV prevalence for different groups. And you can see there's a pretty big difference on what we see between transgender men and transgender women. And we also can see that both groups have a much higher HIV prevalence than we see in the general US population. So it's around 3% for transgender men and about 14% for transgender women. And the story gets more complicated if we look at the intersections of race and gender. On the left-hand side of the slide is the prevalence that I would say probably the best HIV prevalence data we have among transgender men by race. The CDC study didn't have enough transgender men in it that they felt comfortable reporting a racial breakdown of HIV status. So this data is from Dr. Asa Radix at the Cowan Lloyd Community Health Center in New York, drawn from their clinical data. And you can see the data broken down by race, where the blue bar is for white transgender men, orange is for people of races other than white, Black, or Latinx identities, gray is for Latinx identities, and yellow is for Black. So the colors don't correspond at all to any race. And you can see that among transgender men, the HIV prevalence is around 7% compared to around 2% for other groups. So 2.5 times what you see. On the right-hand side, when we look at transgender women, this data is drawn from the CDC study. You can see that the HIV prevalence also varies significantly by race, with the highest prevalence among Black transgender women. And you can see that the number is extraordinarily high. 44% of Black transgender women are estimated to be living with HIV. So given that information, it's really important to understand their perspectives on all aspects of HIV, including HIV cure research. So in thinking through that rationale, we wanted to look at what are the ethical principles around conducting research. And it really compels researchers to ensure that both the risks and the benefits of any kind of research, including HIV cure research, reaches everybody who's heavily impacted by the topic under study. And we could find no published studies on transgender women's participation in HIV cure research, and we felt that it was important to have their unique perspectives included when we think about the ethics of HIV cure research. So our main research questions were to look at what were Black transgender women's perspectives on HIV research in general, HIV cure research in particular, and their participation in it, to look at their perceptions of HIV treatment and treatment interruptions, and to provide us some considerations that were specific to transgender people in terms of engagement in HIV cure research. I'm a fast talker, so I'll try to slow down a little bit. So what we did is conduct 19 in-depth interviews. And by in-depth interviews, we mean we had a guide with some open-ended questions and really probed around those questions to try to understand and dig into the women who participated, what their thoughts and feelings were around the topics that were raised in that interview. We conducted 2 interviews with 9 of the women and 1 interview with 1 of the women who didn't come back for the second interview. The first interview focused on their perspectives and barriers and facilitators to cure research. And the second really dug into their perceptions of cure strategies, broken down into 3 broad categories that you see on the bottom of the slide. We asked specifically about latency reversing agents. We asked about gene therapy and stem cell transplants, and we asked about therapeutic vaccines. And of course, most people, including me, didn't have a lot of background on those kinds of strategies. So we used a document that was developed by the Women's HIV Research Initiative that provided sort of a plain language description of what these strategies were. And we provided that information to participants and then asked them about their thoughts about those approaches. And I don't have a lot of that data on these slides because I wanted to make my talk brief so I could talk about what was important for folks who came to this session. To do the analysis, we made sure that we recorded all of the interviews and they were transcribed verbatim. So every word that people said ended up on the transcripts. And we used a code book that was designed in advance based on the research questions that we had. So that's what we mean by a priority. It was designed in advance. And one initial coder used those codes to attach meaning to the different sections of the transcript. So basically chunk out. So this section, say, is about distrust, right? So we would put a label or a code called distrust on that section. And then we used software to help us analyze that. And that software that we use is called MaxQDA. It's one of many types of qualitative analysis software that keeps us from doing what we used to do in the old days, and I'm going to date myself, which is take the transcripts, cut them into little pieces, and then arrange them in sections. Corrine is old enough to remember doing this, but now we have software to do that for us. And then there were 3 investigators who basically read and reread the transcripts, read and reread the codes, and looked for themes that we saw across either different participants or within a particular participant's descriptions. And that's how we analyzed the data. We also asked each participant to give us some brief demographic information. And I have that here. It's broken down in these categories to try to protect the confidentiality of the participants. With only 10 people, the more detail we provide, the greater the ability to identify them. And we, of course, wanted to maintain their privacy. In general, the age of participants ranged from about 30 to 71 years old, with the average age being 45. And you can see the breakdown there by the 3 categories. Most of the participants have been living with HIV for at least 10 years, with the average years being 12 since they had been diagnosed with HIV. Every person was engaged in HIV care on antiretroviral therapy and reported having an undetectable viral load. 9 participants had a high school education or greater, although none had completed college. The sources of income, you can see that most people got income from disability or Social Security income. So not a wealthy group of people. And let's move to I'm moving around pictures of you all so I can get to the yes, and this is the information about the people everyone being in care, everybody being on ART, everybody being undetectable, and 9 out of the 10 participants completing both parts of the interview. And so the last section of slides is really just going to be pulling out some quotes that represent some of the conversations that we had around HIV research, HIV cure research, and specific issues for trans women in particular. And here you can see that perceptions of HIV research were sometimes quite positive, like the person at the bottom who said, I would be dead right now if people hadn't done research. That's why research is very important. So people understood that. There was also some concern, and people expressed that people were afraid of research, and you can see that in the top quote, and I'll just read it to you. I think when you hear the word research, you think experiment. You think the person doesn't know what they're doing. I think people think of it as researchers are dissecting you, trying to make a plan or something. So I think most people are just fearful of the word research. And I think that's broadly true across many, many groups of people. And when people talk specifically about HIV cure research, there are lots of people who feel like there's already a cure for HIV that's being kept from people. And this has been a theme that's run through many communities over a long period of time, that the cure is available to people, but not to most people. When people were asked about what were some reasons to participate in HIV research, their reasons were mostly altruistic. Like the person on the left said, there are hundreds of people that have this disease. We need to help one another and do this research that helps one another. Because there is a cure out there, you get enough people together, hopefully they'll participate in the studies and eventually there'll be a cure for it. And then the person, a quote from another person said, I just know, like, if we have studies and stuff like that, I'll go and participate because I figure the more people they can get information from, the better, especially in dealing with the transgender community. So some people really felt an obligation to donate their time and energy and information to contribute to the community of people living with HIV and to contribute to the transgender community. People had very positive treatment experiences of HIV treatment. And I think that's probably because we talked to all people who were undetectable and on treatment and had been living with HIV for a long time. And this is a quote that somebody talked about. They have a lot of stability with their medication. They're really afraid of doing something different. They'd have to have a lot of faith in some other option, given their good experience with HIV treatment. And that was one of the concerns that people had about any sort of cure strategy that involved a treatment interruption. And here's a couple of quotes where people are more explicit about their concern about treatment interruptions. The quote on the left, it only takes 24 hours for the medicine to leave your system. So once it's gone out of your system, the virus starts mutating, starts making copies, and they'll be trying to give me the cure to take during that time. So this person's basically saying, as soon as I stop my medicine, I know the virus comes back, and I know when the virus comes back, it starts mutating, and that's a risk for my health. And what are you going to be doing for me to help me while you're doing your research on the cure? Right? And then the person on the right is really clear about the emotional response of fear. Like, my goodness, I'd be very curious, but I'd be fearful of stopping my HIV medication because I know how fast the virus can grow. So people are well educated about how HIV medications work and the risk of stopping treatment. And then I skipped all those other things to make sure that we have time to talk about the considerations that are specific for transgender women. And I can't emphasize enough how often this comes up in every research study that I've ever done with trans women, is that they have so many competing priorities. They're concerned about their general well-being. They're concerned about getting a job and employment, given what we know about employment discrimination against trans communities. They're concerned about access to gender-affirming care, meaning hormones and things like that, but also being treated in a gender-affirming way. So people use the right pronouns and use the right names when engaging with them. They're concerned about their mental health and behavioral health, about their physical safety. And some participants talked about just the danger of getting to a research site if they have to take public transportation, for example, and the amount of violence that they face when they're out in public. And about the complexities of navigating romantic relationships in the context of HIV, and as a transgender woman who might experience transphobia even from romantic partners. And I wanted to close with some of their recommendations and then some of our recommendations that I've broken out by major themes. People talked a lot about how important respect was for them. One person talked about not wanting to be singled out. They wanted to be treated like everyone else because they're human, regardless of their gender or their race. It's a person just trying to help find a cure. Another person was really clear and to the point, just don't disrespect me, that's important. And I didn't include this here, but one person did talk about her experience participating in an HIV research study and being misgendered the entire time that she was there and feeling really uncomfortable and not coming back for future visits, and how, discouraging that can be when we're trying to encourage people to participate in research. A lot of participants talked about how important it was that they have accurate information. The quote from a person at the top said, everything they know, we should know. When it's done and the cause and effects and side effects and all of that, everything, all the information. And I think that researchers probably don't do a great job of providing all the information. And the second person talked about the quote here talks about the importance of honesty. Just be honest. It won't take much. You know what I mean? If you're doing something and there's a choice, I think it's very important to always make sure the person knows that they have a choice. So they're speaking both to sharing information and also avoiding coercing people by sort of tipping the kinds of information that you provide or suggesting that, of course, this is the thing that you should do, but making sure that that person is always in the driver's seat and knowing that they can make their choice about whether to participate or not with full information. People talked a little bit about hormone therapy. As we saw before, people were very reluctant to stop HIV therapy to participate in a cure study, but people were more willing to stop hormone therapy to participate in an HIV study, which was really interesting to me as someone who's done a lot of research with trans community members, and knowing how much people prioritize their hormone therapy as a way to live their authentic lives, and that people were willing to stop that in order to help find a cure, I think was really meaningful. People, this was really salient to me. A lot of people talked about wanting to be genuinely cared for and supported by researchers who wanted to engage them in studies. This person said, this is where we got the title, I would really want to know they had my back. If something went wrong, are you going to make sure that people know that I'm doing this, or I was in this situation? Are you willing to make sure I'm okay because I decided to try something that was supposed to benefit everybody else? The second quote, one of the participants said, you have someone's life in your hand. You're controlling his health, and you have to worry about that person who you're experimenting on. And that's what I should really consider. I'm not just a cadaver, I'm a living person. That could have been another title. I'm not a cadaver. And people talked about, some participants talked about using research as a platform to help support trans community building, which I thought was really innovative. And this person in particular talked about the importance of talking to other people in the community, other trans women who have participated in this study. Have someone that's gone through it before, that you give their experience. It'd be another way to soothe the mind of someone who doesn't know what to expect. So it's one thing for a researcher to say, this is what you can expect. It's another thing for a person who's been a participant in the study to say, this is what my experience was like, and really give that lived experience perspective. And I just want to close with the recommendations that we put for other researchers at the end of the study. And these are ways that I think researchers can help to address some of the concerns that were raised by the women who participated in the study. We recommended that they complete the really comprehensive training that DAIDS has designed in their cross-network transgender working group. All of their trainings are available free and online as e-learning modules, and they have in-person training tools to be used as well, and they can be accessed through the learning portal. And I happen to know the person who's in charge of that is on this on this webinar and can provide more information if she chooses to do that. But they have 5 really great modules that were designed in collaboration with leaders in the trans community. The second recommendation is to think about the design of the research protocols, make sure that they are approached with a gender-affirming racial equity framework, and use a trauma-informed approach. And people don't often think about, well, at least I haven't heard people talk about trauma-informed research. I've heard a lot of talk about trauma-informed, but trauma-informed research, I think, is really important to think about. Who are the people that are going to be coming into your study? What kinds of trauma have they experienced? How can we minimize re-traumatization and provide benefit for people who participate? The third recommendation is to train or mentor researchers from the community. Hire Black transgender women on the research staff, mentor and support Black transgender people who want to be researchers themselves, engage communities in that way. The fourth recommendation is to ensure that participants feel welcome at the research site, that they know about research opportunities, that they can provide, that the people who refer them can provide information on how this particular research protocol might affect transgender community members in particular. Establish partnerships with trans organizations that have experience working in their own community, and can make sure that the protocols that you design and the strategies that you have are welcoming and affirming to the community. And finally, initiate and maintain dialogue about HIV cure-related research with the Black trans community. For example, share information about HIV cure research in community forums. One of the participants in this study talked about how she had participated in a whole bunch of studies, but she never ever found out what happened. She shared her information, she gave her data, her blood samples, whatever she gave, but nobody ever came back to her as an individual and said, hey, thank you so much for contributing. This is what we learned from what you did. And I think doing more of that would really go a long way. And I want to stop there because I also noticed when you asked for questions, people had a lot of things to say. So
they did indeed.
People can benefit. We need to address community concerns. I want to acknowledge all the institutions as well as the individuals that made this study possible.
Yes.
And let's have conversation.
All right. Yeah, so there were a lot of questions that people had, and I want to give us each a chance to share some of them. I wanted to start off with one of my own, and Tonia and Karine, you could also be included in this. What was the most surprising thing that you learned from this study? Something that surprised you?
I want Karine to answer that because she told me what was surprising to her.
Okay, great.
I don't want to speak for her. Do you want to tell us, Karine?
Yeah, for me, it was something that Tonia did not really present was how the transgender women perceive the different HIV cure research strategies. So it was really interesting to see how they formulated a just understanding of like therapeutic vaccines or latency reversing agents. And I think we need more research like this to really understand how people understand these different modalities and attribute meaning to them. Because I think that could really help us with engaging diverse communities in this kind of research. Another thing that surprised me, which Tonia sort of talked about with the racial equity and social justice frameworks, is we will definitely need more intersectionality in this type of research as we scale up treatment interruptions. We will need to adopt intersectionality frameworks in how we implement this research moving forward.
Thank you for sharing that.
Michael, can I ask Karine a question?
Sure can. Please go ahead, Linda.
Karine, what were the differences in the strategies that you saw or that you learned people were expressing?
Well, what she told me was she was super surprised at what people thought was safe and what people thought was risky compared to other groups.
Okay, thanks.
Yeah, and it's pretty well spelled out in the paper. But participants fear repercussion of reactivating HIV reservoirs when it came to latency reversing agents. Somehow, several people thought that cell and gene therapy was safe, although there was a lot of variability in how people perceive these strategies. And then therapeutic vaccines, a lot of them attributed military metaphors to these therapeutic vaccines and also were reminded of the flu vaccines. This was pre-COVID also. So we have to remember that COVID adds another layer of vulnerability during these treatment interruptions. So I think we'll need more and more of these types of studies to understand post-COVID what this research means.
Thank you for that. I wanted to bring to voice Moses's question. He was asking, he says, educate me, how and why are transgender HIV cure research concerns different from other orientations, other genders? So Supercharger was wanting to know if we could discuss that.
Okay, I love that your name is Supercharger. I think that we weren't sure if they were different or not because nobody had ever asked them. And that was the point of the research. Like when we looked and we really found that like there was nowhere visible in all the HIV cure research that we found published, the voices of transgender women who, as you saw, 44% are living with HIV. All of the studies that I've seen, this disparity is really obvious, and my cat is coming to share her thoughts about it. And so I don't think our thought was that, oh, they'll be dramatically different from other people, but our thought was we won't know if we don't ask, and their perspectives are really important.
Thank you. Cher Story wanted to know, after being excluded from HIV research for so many years, what must we as researchers do to regain trust? Are we unreasonable to expect participation?
I think that's a great question. What do we do to, I think, let's see, what's reasonable is a different thing. I think we have to acknowledge the history of mistreatment in research by communities of color and by lots of other communities. Like, we can't move forward with like, well, that's the past and this is the present, because that's not actually the truth. And then I think we need to be clear about what we're doing differently than what's done in the past that should engender trust and support. And those equity lenses, thinking about intersectionality, being gender affirming, most importantly, engaging trans communities from the beginning instead of just like for recruitment. But what are the research questions we should be asking? What does the community care about? Are we hiring community members to be part of the research team so that they are paid equitably for their contribution as part of the research team? And then how are we implementing the research in a way that is justice oriented?
Mm-hmm.
I don't know if Corinne wants to add to that. I feel like I'm just putting you on the spot. But
I agree with everything you said.
Can I do a follow-up?
Yes, please.
For years, exogenous hormones excluded people from being in any kind of HIV research. How do we get them to rewrite these protocols so we can get people in? This is a question not for you, but in general, we all need to be saying this out loud at every ACTU study meeting or Cure Research study meeting, that they need to write the protocols that will allow transgender women and men into the protocol.
Thank you, Cher. Strongly said. I know we have Tia and Rona on. I don't know if you care to respond or help answer this question for us. Yeah.
I'm not sure I have a specific response to that. I know that we are working to increase inclusion and we are doing what we can, but I think that's something that we have to look into further. I certainly hear what you're saying and we'll certainly look into it.
I mean, I think that's a simple one. It may not be easy, but it's simple. I mean, the people that are the community people on the ACTG that have to really raise the roof about this kind of thing. I mean, you know, I just spent a long period of time getting people with HIV into the vaccine trials, and you know, there's certain procedures you have to do, and mostly it's being involved with the protocol team early enough on to make sure that that ridiculous stuff doesn't happen. And I mean, you've got community people on the ACTG, on the protocol teams. I mean, they ought to be screaming bloody murder about this kind of stuff, and it would go away in a short period of time. You know, they need to be armed with evidence that the exclusion is not reasonable or necessary, and, you know, and be prepared to go to the top if the protocol team doesn't amend the protocol.
Right, and we do have recommendations and guidelines saying that transgender people should be included unless there's a scientific reason for their exclusion, and so that it needs to be stated why they're not being included, and be very clear. But that, you know, we have recommended that, and we do have these guidance documents, and we have to really work hard to make sure that they are followed. As you said, Linda, to have community people who are reviewing the protocols and to continue to push for it.
And Linda, you had your hand up. Did you have another question? Do you want to?
Yeah, I wanted to. I was thinking about the differences and the things like that. You know, at AIDS Action Baltimore, we've had a lot of programs for African-American trans women for many, many years. And, you know, it's not just that the researchers need to be respectful and cognizant of what's transpired and admit all that sort of stuff and try and make people comfortable. I mean, the person that meets them at the door, the receptionist, that sort of thing. I mean, if you would hear the stories that we've heard about how people are treated and made to feel less than, even when they're trying to register for a clinic appointment or something, and then they just will never come back. You know, I wouldn't blame them. We do the same sorts of things. So that was one point. And the other was about the differences. I mean, I think that the trauma factors or the trauma sorts of issues that Tonia alluded to are it's probably that and the hormone stuff. I mean, you know, these are people that have had their lives in danger. So, I mean, you don't come out of that without having a lot of trauma and trauma related sort of behavior and just PTSD sorts of stuff. So, I mean, I think that is extremely important for researchers and staff to understand. The idea of having somebody that looks like you in the waiting room or being there to help you. I mean, we've been advocating for that for people of color all along, but it's even more important, I think, in you know, these trauma issues. Of course, you know, if you live in Baltimore, everybody from African American communities has dealt with all of this trauma related stuff. So, I mean, it's everything. It's so important to build trust, and you know, you have to. It takes time to do that, but that again too, it's not hard stuff. It's just it takes some work to get it accomplished.
Thank you for that. Beth,
I wanted to make a comment.
Sure, please.
I think my experience and understanding of research when it comes to especially phase 1 and phase 2 research is that the participant may be restricted to not being able to take as much as a Tylenol when it comes to clinical drug studies, you know, for fear of it marring sort of the impact and the PK around the therapeutics that are being studied. So it's not one of those things we should look at as being a matter of restriction or trying to bar trans people from being able to take hormones, but to look at what these types of studies should be designed in maybe like a phase 3 study where you're preparing for real world or market release, where then it would be applicable for something like data around what exogenous hormone use looks like amongst this population. So, you know, it's one of those things where we say that we understand that these hormones should be included in the study, but need to take into consideration when is the appropriate time and when they're not. That is really based around science and not someone being prohibitive or restrictive as a matter of punishment or not being reflective of how it's necessary to include these things, because they're a strong part of trans people's lived experience in clinical care.
Thank you for that. We had a question from Beth Peterson that was maybe a simpler question to answer for either Tonia or Karine. It was, were any of the participants in your study currently or in the past in a participant in a cure-related trial?
No.
Nope. I figured it was an easy one to answer.
Yes, that was pretty easy. No.
So what other questions do we want to talk about? Please speak up.
I'm scrolling.
Well, you know, I think that retention is just as important as accrual. I mean, it might be easier to get people in and harder to keep them in. So, I mean, I think that Tonia might have a lot of experience on what might be helpful in that regard. And let me just say too about that whoever commented about the phase 3 stuff. I mean, I, for one, don't know why most people get in phase 1 trials, you know, but, and to what Rona said, you know, you may have a guidance. So I think the leadership also needs to make sure that, protocol chairs and the heads of different committees know that trans people should not be excluded unless there's a scientific reason. I mean, if you get enough evidence of that from the community or elsewhere, it may need to come from the top to get that message down. I mean, it's like the FDA and their guidances. You know, there are companies that listen and there are companies that don't. And I think researchers are the same way. So, you know, I know I said the community should scream bloody murder, but it should also come from the top, and that would make it happen a lot more quickly. So Antonia, so what do you think about retention? I mean, you have any tricks, any ideas about, you know, what works and what doesn't? I guess I shouldn't have said tricks, but you know,
like,
strategies.
I mean, one of the things that we've accepted is that when people have difficult lives, so trans people experience a lot of unemployment, discrimination, and so their lives are very mobile. So if you have many sites so people can enroll in one and re-enroll in another, that's very helpful, but also things happen, right? Not everybody can consistently come to your site every, whatever, 6 months for years. That said, I think the more people care about what you're studying and know about what you're studying. So what came through a lot is people had a lot of questions for us. You know, some of the answers that, if you read the paper, many of the answers to our questions were more questions. So people are not being fully informed about what the study is about, how it would benefit them or anybody else. And I know for the LIGHT study, which is a longitudinal cohort study we've been doing with transgender women in multiple sites across the US, people feel like they're part of something, right? This is a first 1,200 person longitudinal cohort of trans women that's asking questions about food insecurity, about violence, also about HIV, but also about whatever the community has told us was important. We tried to include that. And they get logo and swag and like, this is for us and about us. And I think that's what keeps people engaged, feeling like they're part of something important that matters, that benefits their community, and being fully informed about what it is that they're contributing.
Mm-hmm. You know, one of the things we did, I mean, this is a cisgender women problem too. And one of the things, I was involved in the GRACE study for 100 years ago, and we've been banging on the doors of pharmaceutical companies to include women and people of color forever as well. And you know what they found, because they initially found they got people in and couldn't keep them, was the same sorts of things that you're saying, you know, and having people involved and interested, engaged in the actual study and its outcomes. But also they had support groups that were associated with the actual studies, where there was, you know, not only collegiality, but camaraderie among participants, and, you know, relationships with the nurses and whoever, you know, was at the support group or might have been come to deliver a talk or whatever. You know, so it was like one big happy family sort of approach, which is what we try and do with our programs for all people. You know, if they like you and trust you, you'll see them again. So.
Thomas, you had your hand raised.
Yes, I just wanted to sort of follow up on Linda's point. I think one of the themes that I see across many different studies, and the issues similar to what we're discussing here about recruitment, retention, people understanding what's actually being studied, et cetera, all of this really comes down to the need for effective community engagement. And community engagement really needs to be considered a continuous relationship, best formed and maintained through a community partner or community partners. If our definition of community engagement is limited to whatever I do as a researcher for my study, and then at the end of the study, I go away and go back to my lab, and that's the end of community engagement. I mean, that's a pretty limited and ineffective, if you will, and certainly not efficient means of community engagement. If we have a long-term relationship with communities, then, as Linda mentioned, we should expect, assuming we treat people well and that our studies are meaningful, we should expect to have people continue to come back and participate, which is what we want.
And I would say it's bi-directional too. I agree. Thank you so much for saying that. I agree. And I think that part of showing people that you care is not only that you show up when you ask them to do something for your study, but that you show up for stuff that's important for them. So if there's, I don't know how people feel about marching on Washington or whatever, but if there's like an event that people in the community are leading that matters, that you show up. Like I try to show up because it matters to me, their well-being beyond their participation in a study. The whole point of the study is to help people live better lives. So they're also doing something through their community organization to help live better lives. How can I contribute to that? So it's a bi-directional relationship.
Absolutely. Yep.
Too, Tonia, what we do here, and I know you know this, but we have what Tom just said, long-standing community engagement strategies. And, we have researchers come and talk about their protocols. And, I'll hear from people at Hopkins, well, nobody wants to get in research. Well, they don't know you. Why should they just, spend the day trying to find their way around Wolf Street? You know what I mean? But it's unbelievable. I mean, I have watched this for so many years. The researchers come in, they talk to people, they answer questions. It's no different than any other human sort of communication or relationship. They get to like you, or they like, you can tell in a 45-minute presentation whether you like somebody or trust somebody. And, you have your first impressions. I mean, that might not always be correct, and you shouldn't, have your life revolve around the first 45 minutes. But I mean, if you're talking about getting a person engaged in what you're doing and in your work, I mean, that's a good start to come to where the community is, and to be on their level and to be able to present on their level without, millions of charts and confusing things that make people just irritated that, that you're talking down to them, that sort of thing. But I mean, it's really not rocket science. It just takes some commitment to meet the community where they are regularly.
Be a person. I think you hinted at this, but I'm going to say it more explicitly, like just show up as a human. Like I don't show up as, when I was at Hopkins, I didn't show up as like a representative of Hopkins because
right.
But I showed up as Tonia, and this is why I do this, and this is why I care, and this is what I'm trying to accomplish here. And do you have any questions about me as a person, as well as about the study? Because I'm going to ask them a bunch of nosy questions.
Right. Well, that's the kind of thing people can pick up on in 45 minutes, whether or not you're where your head is and where your heart is, what your intentions are, that sort of thing.
So we're at about the 15-minute mark before we end, and I just wanted to make sure that I'm trying to go through the chat and see people's questions, but I want to invite the people who may have put a question in the chat, and if you haven't seen it answered yet or heard it answered yet, to please speak up and add your question, because I'm trying to go through the chat, but I'm afraid I might be missing some of those questions.
One of the things I wondered about is when it comes to exclusion from research, I've been in the same boat where 99.9% of research that I was interested in, I was excluded from because I had cancer, I had diabetes, I was on Coumadin. I wonder if you could explain how those exclusions are, why those exclusions are important to the research.
Well, I'm going to do my best because I don't know what the specific studies are, but I know that I have a cynical answer and a not cynical answer. I'll give you my not cynical answer first, which is that researchers really want to not do harm. So they're going to be as conservative as possible about who they enroll to start with so that they can determine whether or not the medication or the intervention or whatever is safe before they expose other people who might have more negative impacts from it to the research. Because as you know, like we don't know if whatever we're studying works yet because that's why it's being studied. My cynical response is that especially pharmaceutical research wants to have the best outcomes possible. And people who have a lot of other risk factors are probably not going to have the best outcomes possible. So including folks with other issues in the study might make their product not look as good as it could otherwise. But that's the cynical me. Listen to the more optimistic me about the desire to protect participants.
No, too, Tonia, it's as much that they want to get it done quickly too, because they make more money the sooner they get it out the door. And it's easier to deal with men that don't have children and, don't have as you called, mobility issues for the trans community. It's just much easier for them to say, okay, this is, I mean, that's really cynical, but it's really true as well.
Yeah, I think that's why the principle about thinking through who is actually going to benefit from whatever your intervention is, and those people should be in the study. So like, the vaccine studies precluding people with HIV. It's not like people with HIV weren't going to also need a vaccine.
Right.
It didn't make any sense. And I think that's the argument y'all made so effectively.
And you're talking about the COVID vaccine.
Yeah, sorry. COVID vaccine.
Yeah. That and a great big hammer.
Yeah, I wouldn't want to come up against you, Linda. I'd be like, yes, whatever Linda says.
Looking here through, I know like people were talking about trauma-informed care, and I'm not sure people really understand exactly all that means. Would you be able to talk a little bit more about how that would apply to transgender women, especially Black transgender women?
Sure. I will first do another plug for Rona and the and the training modules that are available for free online. There's a whole module on trauma-informed care and trauma-informed research that I encourage people to look at. Even if you're not a researcher, you can hold the researchers you work with, their feet to the fire to these principles of trauma-informed care. But I think that in broad strokes, understanding that people come to us, as Linda mentioned, with this long history and experiences of not just post-traumatic stress, which I think is a misnomer, particularly for trans people in this country. It's ongoing complex trauma, because every time you leave your house, you're wondering, am I going to be a victim of violence? How are people going to treat me? And am I going to be misgendered or misnamed? Like, this is a chronic, ongoing experience, not a big thing that happened and now it's over. So being cognizant of that. And what I try to do is like think through as much as I can understand about a potential participant's experience in the study, walking through every bit of it from like, I see the flyer, I make a phone call, I show up. What happens to me and how could that experience be re-traumatizing? And what can I do as somebody who's designing as much as I can that experience do to reduce that experience of trauma at each step along the way? And I think that's my simplistic, I guess, understanding and way that I think about it. And I think about that for my patients too, when I provide care, like, what is it that I'm doing that could be re-traumatizing, and putting as much power and control into the hands of the other person who's in the experience as I possibly can. I mean, not usually letting people draw their own blood, but I mean, as much as possible. What can that person completely control?
And there've been questions about the design of protocols that have been, I see throughout. I'm trying to boil them up into just one question. I think Bill hit it. How would you design a protocol that would be able to educate and ease the fears that transgender people would have of research?
I think that comes back to education. I've done other studies looking at people's engagement in HIV research, not specifically cure research. And a lot of it is when people hear the word research, they think of injecting them with things or taking things from their body, and not all research is that. So explaining what is research and what does this particular study seek to do and how and why you're doing it that way. I mean, it's just basically explaining things to people. Yeah. I think goes a long way. Like one of the participants said, just be honest. Whatever you know, they should know.
I think that's important. I think we forget that whenever I hear qualitative data like this, I always just think these people are the sanest people that I've heard from, because their concerns are just what I would ask if I were being asked to do a gene therapy study. And I know sometimes researchers take it as gloom and doom when they get all these sorts of responses about, oh my gosh, all these things. But to me, I'm like, well, if you were asking me to do something like this, I would have those same questions and I would expect those same answers to come. So I think what we're talking about is just common sense. If you look at it from a participant side, what would you want to know? You would want to know all of these things before you take some sort of new substance into your body or some sort of new technology or new procedure. You would want to ask all those questions. So we are almost up to time. I wanted to give anyone a last chance for a last question that they may have.
I have a question for Tonia.
Go ahead.
So Tonia, you said, you mentioned trust and mistrust and distrust. Can you explain the difference between trust versus trustworthiness? It's not something that people lack, but something that we must build. So maybe if you could talk a little bit about that, that would be really helpful.
Thank you, Karine. I didn't even plant you to say that, but I have two comments to make about that in terms of words that we choose. I hear lots of times medical mistrust, which implies that the person is mistaken about not trusting a system or a group. And I use the word distrust, right? Because I don't trust you, but I have probably good reason for not trusting you. And then the responsibility is not on me to let go of all that I know about my experiences in healthcare systems and my experience in research in order to, have some completely uninformed trust of you. It is the responsibility of that system to demonstrate that they are trustworthy. And I think that is, where does the onus lie for building trust? I don't know if you wanted to add to that, because that's what I think about. And I think that's really important for us to consider.
I think you hit it on the nail. Distrust. I never think that it is unwise of people not to trust. I always think that again is a sane response, given the history of just Black people and research in the US. How can you ask them just to forget all about that? Mm-hmm. I mean, it is a history that is bloody and it's awful, and you cannot deny that. And so we need to really combat that the only way possible, which is to admit to it and to then work actively to build trust, to show how these things will never be able to happen again, and to really prove yourself. You have to prove yourself.
Yep.
Well, I think maybe we've reached the end of our little hour-long conversation here, but I wanted to take the chance to thank each and every one of you for joining us. This is an important talk, and I think this is just the beginning of such conversations, especially when it comes to involving transgender people in cure-directed research. So I wanted to thank you, Tonia, for helping us have this conversation by doing this work. You have, I hope, some plans to continue this on, taking what you've learned here and taking that, as all good researchers do. I didn't know if you want to maybe leave us with some ideas of future directions you may be taking with this.
Well, I think the goal is to make sure that every research study that's ever done includes transgender people. Like, I don't understand.
Amen.
Right? Like, there's no research question that doesn't apply to trans people as much as it does to cis people. So that is the ultimate goal, to be as broadly inclusive as possible in all research studies.
Thank you for that. And I think we all could take that as a mission. I think everyone, either on either side of the equation, whether you are a researcher or a community advocate, I think we all need to be pushing for that to make that actual change happen. So I wanted to thank you all for joining us. And I wanted to also take a chance, knowing that you are a Taurus, Tonia, you have a birthday coming up. So I wanted to wish you an early happy birthday. And thank you for taking the time for joining us for this and letting us talk about this research. I think it's really great that you helped break the seal, so to speak, and allow us to start talking about this even more.
Thank you.
Yes. Thank you
Great
all.
call. Thanks, everybody.
All. Yes, thank you all for joining us.
Nice to see you, Tonia.
Have a beautiful week.
Bye.
Take care, everyone. Bye-bye.
Thank you.